Good morning or afternoon, you all, depending on what time they're running this tape. I apologize, first of all, that I can't be with you in person. I've got some scheduling conflicts, so some of the psych skill days I am not physically in the state, so I wasn't able to do them, so I apologize in advance. I will still try to make this entertaining because I know it's painful to have to watch videotape. So I will try to make it as positive as I can, given that I'm not actually in the room with you guys. So today what we are going to be talking about is cognitive disorders, also known as, and your name is? Exactly. So
what is your name?
I'm Heidi Combs. Do I need to introduce myself? I'm Heidi Combs. I'm one of the inpatient attendings. Probably most of you know me. I love doing education, so they let me do this almost every year these days. So that's me. So at the end of this, I'm hoping that you'll have a sense of kind of how common cognitive disorders actually are, and specifically with some of the psychiatric disorders that we often see at Harborview, what kind of cognitive issues you can see with those disorders. Then I want you to be able to perform an assessment for various cognitive domains, which is going to be the fun part because you all are going to be testing each other's cognition. I know it, it's going to be pretty good. And then we're going to talk about how you might apply some of this information to actual patients that you're taking care of. So that's what we're going to be doing today. So you guys know this, I'm guessing. The US is getting older. We actually are also getting older. As we speak, we're getting older as we sit in this very room, but the US overall is getting older. By 2030, there will be approximately 70 million old folks, elderly folks in this country. Currently there are 48 million. So there's an aging of the population. What happens with our cognition as we age? Do things stay just as they are when your brain is a perky and plump 25, or have you guys noticed anything about your cognition? So my little thing says here, because it's kind of blurry, it says, I can't remember what we were arguing about. Let's just keep yelling and maybe it'll come to us. So talk to me about what you have noticed about your cognition as you guys have aged. I know some of you were quite young, so you may not notice things. I'm not so quite young now, so I notice things. So things that you have noticed about yourself or about your parents or your grandparents. What are things that you have noticed that people seem to have occurred as they age? So since I'm not in the room, I'm hoping that all of you are now yelling things out at my image that is in the room with you, but I'm not here. So I'll tell you the thing that I noticed. I cannot remember people's names. I've always been bad, but now it's like really bad. And just this morning I was on the unit, Sue, for when you watch this, you'll remember this episode. I was showing her the ring that I was wearing, and I said, and I had this stone put in, and I'm like, I can't remember what the name of this stone is. These are the kind of things that people have commonly happen when they age. So specific things that people will experience. This is what the data shows. As we age, things that we do repeatedly. So you think about driving, for example, is a task that actually has a lot of complex parts, but you've done it so many times, you don't think about it anymore. Understanding what the traffic lights mean. You know that. It's rote information for you. We actually hold on to many of those things actually into the 7th decade, and then they start to decline. So some things we hold for a while, but they do start to decline a bit. Attention span decreases. So do you have any grandparents or aging parents, or perhaps you've noticed in yourself, that you don't stay on a task for as long of a period of time? And if you're in an environment, or someone that's older is in an environment where there's a lot of stimulus going on, they get distracted. So their concentration and focus, if there's a lot of distraction, is worse. So these are normal things that happen with us all as we age. The thing that gets most impacted by normal aging are working memory and executive function. So I just want to review what working memory is in case people are not familiar with exactly what that term is. So working memory are the things that we need to have kind of on the table in our head when we're making decisions about things. So you're going to be thinking about whether you're going to want to buy something that you see at the store, and you're thinking, how many of these do I already have in my cupboard? Do I have the money in my checking account to pay for these things? Is there a chance that my partner's going to bring the same thing home? So you're making decisions based on information that is fluid, but it's relevant to making this decision. And part of that also then ties into the executive function. So executive function are things that you have to do that have complex tasks. For example, doing your taxes is a complex executive function where you have to gather a lot of information, prioritize, organize, assess, plan. That's an example of an executive function task. These things, the working memory, so the things that you need to keep on the table, and how you process and organize those things, often starts to decline in the sixth decade, and it continues to decline. This is part of normal things that happen for folks. And processing speed gets a little slower. So do you remember, or have you had the experience of the contrast of when you used to do something and it took you almost no time for processing, and now it just takes a little bit longer? Or maybe you've seen this happen with your parents as they age. It just takes a longer period of time for them to kind of go through tasks. That's a normal part of aging. However, if you think about, if that's the case, it's going to affect how they're assessed on tests that are timed, which you guys are going to be experiencing shortly, just to give you a little preamble. So this is, again, a normal thing that happens. So our problem-solving skills, reasoning about unfamiliar things, sadly, it peaks at 30. Isn't that sad? I've been going now for a long time. So you think about novel situations. Older folks tend to not do so well in those situations. They get overwhelmed in those situations. They want to be in situations that are familiar because of exactly this reason, that problem solving and processing unfamiliar things tends to not be as effective for folks. They're not as good at it as they are when they were younger. Verbal fluency, this and naming of objects. This is what I was alluding to kind of earlier. It declines particularly after the age of 70. So that word finding thing, you'll notice. My stepfather did this. Started in his mid 70s, where he'd be trying to tell me something. It's like, oh, I can't think of that word right now. It's just like on the tip of his tongue. That's a normal thing that you'll see that occurs with aging. And some of you are going to get to practice this with your colleagues today. I have 2 different tests you'll be doing, and one group of you will get an opportunity to show your skills in this area. I told you about a whole bunch of stuff that gets it goes down as we age, but do not be depressed. Do not despair. The data shows if you actually stay very engaged, learning new things, remain physically active, you can help blunt some of the changes that happen with aging. I'm not going to tell you that you can stop aging from happening, because that's actually not true, but it does appear that if you stay very engaged, learning new things, remain active, remain social, that you actually can protect some of the cognitive function you have, which is a positive and a good thing to think about. So don't get too depressed about it. All right, so what happens when cognitive changes go beyond what I just spoke about? So I spoke about processing speed goes down, general executive function, working memory, ability to solve novel problems. Those decline as we age, but it's within the normal range of what all of us experience, or most of us experience. However, sometimes you cross the bridge. You go over what is actually normal aging, and you go beyond that. When that happens, you would be identified as having a mild cognitive disorder, a neurocognitive disorder. In this situation, the things that are being affected actually are requiring people to do compensatory strategies and accommodations to be able to actually maintain independence and perform their ADLs, their activities of daily life. So if people are having to start doing things to make up for some of their deficits, that's when it probably has gone from a normal aging process to actually the person's having some mild cognitive impairment that again would be impacting function at that point. So for you all, what comes to mind? What are tip-offs for you when you're working with your patients that they may be having some cognitive difficulties? So since again I'm not in the room, you can shout at me. I just won't know that you're shouting them out, but I'd like you guys to go ahead and call out some things. So you're working with a patient. What makes you report in team meeting when you're meeting with the entire team in the morning? What makes you want to tell the team that you think that this person isn't processing information, that something seems off in the way that they're thinking? So go ahead and throw out some examples since I'm not here. I'll give you guys a moment to do that. You don't have to pause the tape, TJ, but I just want people to give a moment to think about it. Okay, so things, I'm hoping, some people said things like, patient's not remembering my name, even though I've worked with this patient multiple times. The patient, when I go to change the date, the patient is surprised that the date is not the date that's actually accurate, so they aren't keeping track of the date. You've talked about the group that they're supposed to, the schedule, their medications. They just don't seem to be holding on to this information, or you're talking to them and they just don't seem to be able to process the information that you're telling them. These are some of the tip-offs that maybe there's something cognitively going on. I'm guessing many of you came up with other ideas that I didn't just mention. So some people, I've talked about normal aging, then I've talked about that you can develop kind of a mild neurocognitive disorder when you're starting to have to use compensatory mechanisms to help you accomplish your ADLs, activities of daily living, and your normal activities. Sometimes people with mild neurocognitive disorder continue to decline, so they get a little further down the road. And if they do that, then they actually may meet criteria for a major cognitive disorder. And these are more what we often will see on the units. This is pretty common. So in these folks, there's a significant cognitive decline from a previous level of performance. And this can be figured out by doing cognitive testing. Often we get this from family members or case managers for a lot of our patients that don't have family members that they have a relationship with. It could be from your assessment, because how many of you know these patients extremely well? And you'll say, well, you know, Jilly does not look like Jilly looked 3 years ago. She used to be coming to group, she was engaging. Now when I talk to her, when she's in group, she's not able to follow and process information. Something seems different for her. So sometimes we're actually the informants for our patients that we know well. These are areas that could be potentially impacted. Learning and memory, complex attention, language, perceptual and motor, executive function, and social cognition. So these are all domains that could be impacted by people that have a major neurocognitive disorder. It has to interfere with their independence for everyday activities, and it isn't in the context of delirium. You guys remember we talked about delirium last year? So people that are delirious look quite cognitively impaired at times. You want to make sure that's not going on. And it's not based on another mental disorder, right? So this is not the negative symptoms associated with schizophrenia. This is not someone who's severely depressed, which we'll talk about. So it's not from those things as well. These are the common causes of neurocognitive disorders. These are the ones that we tend to see a fair amount of. So people with dementias, substance use issues, traumatic brain injuries. So Huntington's patients. So for those of you who are on 5-West-B, we have a patient who has severe neurocognitive impairment related to his alcohol use, and he's in his 50s. Right now, we have patients with TBIs that have really prominent cognitive deficits related to those. We certainly have had a couple well-known Huntington's patients on 5-West-B as well. who had quite prominent cognitive impairment related to their Huntington's disease. So we see these things pretty often. Given the commonness of dementia, I want to say a few specific things about that. The prevalence for dementia in folks 65 and older is 6 to 8%, and once you're above 80, it's 30%. This is a common thing. For those of you who are not in the room with me right now, the good Timothy Meeks is in the room with me right now because he's taping this, and you should have seen the grimace on his face. It's scary. It's a little scary, right? Wow, one in the almost 3. Most common types of dementia is Alzheimer's. 5.8 million Americans have Alzheimer's as right now in 2019, and check this statistic out. Every 65 seconds, someone in the United States develops symptoms consistent with Alzheimer's. Holy moly, that's a whole lot of people. So I told you there's cognitive developments that happen as we age that are normal. They can then kind of cross over into being mild impairment. Then they can cross over into being prominent impairment or major impairment. And I told you all those different diagnoses that you can associate with that. For example, traumatic brain injury, Huntington's disease, various dementias. What about the cognitive impact of diagnoses that we see with our patients? So I picked 2 to talk about since they're ones that we commonly see on the inpatient units. Depression. So I want you guys, before I show you the next slide, to call out some of the cognitive impairment or some of the impacts of that depression has on the way in which people think, how they function. So right now, I'm hoping some of you are calling some things out, letting TJ hear it, other people in the room hear it. So we got those out. And these are attention. What happens with attention with people with depression? Concentration goes down. Cognitive flexibility. How many times do you hear yourselves or others on the team talking about, like, this patient is just so ruminative and stuck on this stuff? There's no flexibility with that. You'll really see that with depression patients. We talk about them getting into a rut that they can't get out of. Very common with depression. Executive function, planning, organizing, reasoning, all go down when people have depression. They get overwhelmed with trying to do complex tasks. I just literally today spent time with a patient who has a master's degree who is unable to work on her RAT plan. She cannot get it together to work on her RAT plan because she is stuck in a negative rut and she cannot plan and organize things right now. This is a high functioning person who right now for severe depression is unable to do those things. Definitely slowed information processing speed, memory is impaired. You guys know people that have depression, their memory, they can't remember anything. Slowed with verbal fluency and social cognition. All of these things tend to be lower in people with depression. If you have a patient that is older or who has achieved less education, they will actually have more cognitive dysfunction than someone who's highly educated or younger when they have severe depressive symptoms. And the way I think about it is, if you have had lots of education and you have a nice plump juicy brain in there, you have a lot of reserve. If you're someone who is much older, juicy brain not quite so much, and a higher level of education teaches you all kinds of coping strategies. And if you have less education, you'll have less reserve. So for those folks, when they get depressed, their cognition is more impacted. The other thing to keep in mind is when people are older, I just showed you a bunch of the symptoms associated with depression that people can have. They should look very familiar to the major neurocognitive disorder slide that I just showed you. A lot of these things are in common. So when you have an older patient, how do you sort out that what they're experiencing is from depression versus what they're experiencing is actually because they're developing dementia or they have dementia. So how is it you can sort these things out? And how many of you have heard the term pseudodementia? So pseudodementia is a term that often is used to describe a depressed person, usually older, because dementia affects older folks more, that appears demented, and then when you treat their dementia by treating their depression aggressively, the dementia goes away. So it was a pseudodementia, so it was actually caused by the depression that they had. This is a key thing I also wanted to point out, that some patients, when they have a severe depressive episode, especially as patients age, sometimes they don't quite get back to where they were. And why that is, we don't actually understand. Also, depression increases risk that a person is going to develop dementia. And sometimes dementia starts by actually someone having a severe depressive episode and they never get back, and it's actually kind of the declaration of the dementing process, and their cognition gets worse over time. So it can be a little bit hard to sort out, but we'll talk about there are ways to do so. How about schizophrenia? So I just talked about the cognitive impacts that you can see with depression. With folks with schizophrenia, clearly also cognitive impairments. And you guys know this. I want you to think about the schizophrenic patients that you have worked with on the unit. What kind of cognitive impairments have you noticed? Right. So since I'm not here, I'm guessing you guys are yelling out some things. So we'll get to see here. Processing speed, attention, working memory, verbal learning and memory, visual learning and memory, executive function, verbal comprehension, social cognition. All of these things are things that can be negatively impacted by someone who's thought disordered. And you know, some of our schizophrenic patients have really a prominent cluster of positive symptoms, right? So they have lots of delusions, hallucinations. Others have much more prominent negative symptoms. These are the things you think about when you think about negative symptoms. So how do you sort out whether the person, as they're aging with a thought disorder, are having problems because they're actually developing dementia, or is this actually someone that just has a lot of prominent negative symptoms associated with their primary psychotic illness like schizophrenia? Patients with schizophrenia do perform 1 to 2 standard deviations below the average for cognitive tests. So they don't perform as well on average because of these various problems that I just described. And you guys know this classically in that you'll hear people describe before the onset of, before the voices started, my son was, really engaged in sports and was very social and was doing really well in school. And then we started noticing he was interested in sports and started pulling away from his relationships. And then he seemed to start struggling in his coursework, even though he had always been a straight A student. Then the voices started, right? So often what happens is you look back and you see there's been this decline, and then the illness really declares itself when they start hearing voices or they have a delusion, that paranoia starts. So this is a very common thing that you'll see. Again, not all patients with schizophrenia have this, but the vast majority, or a majority of patients actually do have some cognitive impairment. So what do you do when you have a patient that you notice seems to be struggling from a cognitive standpoint, right? Doesn't seem to be. Awesome. So how is it that you're going to figure out what might be contributing to this, what you're seeing, this cognitive problem? So there's a couple things to think about. Clearly the history. We need to know what did this person look like before? Are there medical things going on for this person? Have they had multiple psychiatric admissions recently? So we want to know what the thorough history. Collateral is super helpful. You know the challenge though with a lot of our patients. They are disconnected from their social support. So the collateral oftentimes is who? Case manager, their ARNP, PA, nurse, physician that they work with. It could be us, right? Because so we know some of these patients over years we watch them change, and so sometimes we're the ones actually providing the collateral because we've worked with these patients over time. the things that we're really thinking about are how are their everyday activities impacted? Because that's kind of where the rubber hits the road. It's not some esoteric thing, but that is how are they functioning? And then I'll talk a little bit more about this with another slide, but then we have to think about physical and neurologic exams, potentially labs, and then cognitive testing, which you guys are going to be doing in a little bit. Just a reminder. So, are these people able to manage their basic needs? Are they toileting? Are they dressing themselves? Are they able to transfer themselves effectively? Can they get around? And then instrumental activities of daily living. So are they able to do things like manage their money, manage their medications, use a phone, get around in their environment, right? So those kind of things. Are they able to do those things? These things are help us sort out how their cognitive function is in being out in the world, which is where they spend their time when they're not on our unit. So we need to know how can they function out in the environment when they're not being supported by us. These are a bunch of lab work things that we do. We clearly want to make sure that this person doesn't have some terrible infection, doesn't have hepatic failure, which we have a patient on the unit right now that has hepatic failure related to his alcohol use, which is severely impairing his cognitive function. Want to make sure that kidneys are okay, that there isn't an infection process going on. So this is kind of the classic, I call it growthogram, where we do a bunch of blood work to see if there's anything going on for the patient. One thing I want to say about reversible dementia is, so we always hear, you got to make sure if someone's having a decline in their cognition, that we look for reversible causes. The classic is, vitamin B12, for example. If you actually look at the data, only 9% of those, when you do all this work, have a potentially reversible form, and actually less than 1% really actually reverse with treatment. So there are things you want to look for, but these are actually things that don't occur all that often. We still look, but just to be aware, it's less likely that we're going to actually see something that we're going to be able to reverse if it's a medical cause of their cognitive impairment. So I talked about there's blood work you can do. Certainly we keep an eye on how they're maintaining their personal hygiene. Are they feeding themselves? Are they able to manage things in their environment? Can they make phone calls when we ask them to? Those kind of things. But then those are kind of general things. Then we start to think more about maybe we need to do some cognitive screening. You guys probably all know, you'll hear us talk about the ACL, go occupational therapy. We love our occupational therapists that do this test. So this is often a screening tool that we'll do. And I don't want to talk about what OT, their realm of what they do, but this is a screening tool that if you're in the 5s, you're golden, right? You got this, you don't need to have any other testing done. If you're in the 3s, you're screwed. Like, you're in trouble. You're going to need lots of support. If you're in the 4s, between 4 and 5, then that's someone who has some impairments, and further testing can kind of help us sort out where these deficits actually lying, and then what can we do to help support them. So that's one thing. The mini mental status exam, we used to do that one. It's called the Folstein mini mental status exam, and some of you probably remember that. We actually don't get to do that one anymore because it's copyrighted, and we have to pay if we use it, and if we screen it and put it in the chart, we could be fined because it's actually protected copyrighted information, so we don't use that anymore. So we've now gone to the MOCA. So some of you may have heard the team talk about the MOCA, and we're going to be talking about it more because guess what you're going to be doing. It's very exciting. And then there's an option of a mini cog. So that's another way, and I'm going to talk specifically about that in a little bit. So these are kind of some of the screening tests that we might do with a patient. So these tests specifically look for various areas of function. So if I have a patient who really only has attention problems but doesn't have any of these other problems, the intervention for that is going to be different. If I have someone who has significantly memory problems, the intervention is going to be different. So these tests allow us to try to narrow down where people are potentially having challenges, so then we figure out what kind of compensatory mechanisms we might be able to come up with. So these are ways of us to see what is actually going on in someone's brain, right? So the frontal lobe is where executive function lives, temporal lobe is where memory and understanding and language live, vision for occipital, parietal, perceptions and making sense, arithmetic and spelling, sensory sensation, and motor cortex is movement. So by doing these tests, in a way it's kind of like we can peek into someone's brain without actually opening up their skull. So what you guys all get to do now is check how your brains are working. So what we're going to do is not have you do interpretive dance, although I would adore to see all of you do an interpretive dance, but we won't do that today. So what you're going to do is you guys are going to get into partners, 2. No more than 2. It doesn't work if you've got 3, so you just have to get into pairs. And if there's an odd number, then just go find a partner. Grab TJ or something if he's not doing something else. So what you're going to do is each partner pair needs to have one of 2 different things. One of them says Montreal Cognitive Assessment, aka MOCA, on the top. You should have one of those, and you should also have one that says Stroop Test. And there's a bunch of boxes that have a bunch of words that are colors, and then some of them are different colors. So each dyad, each pair, needs to have one of each of these things. So pause the tape while everybody gets their little packet. Okay. I'm pretending to freeze. Okay, now. So everybody has their packet. Now you can get the tape going again. So what you're going to do, did I actually make a thing for this? No, I didn't. So what you're going to do is you're going to pick, and I don't care how you're going to pick. How about in your pair, the one that's sitting to the right is going to be the one that is going to be taking the MOCA. So the person on the left, grab this MOCA sheet from the person on the right. So the person on the right is going to be the one that's actually taking the test. The person on the left is going to administer this test. What you need to do is walk through this test with your partner. So there's different tasks. The first task is a visual executive task. There's 2 things in there. Just keep going through. This is a very self-explanatory thing. It says, like for the second one, it says, draw a clock, and it tells you what time it's supposed to show on the clock. Name these objects, and so on. So I want you to test your colleague. This should not take more than 10 minutes. So I want you to go ahead and go through this, and then once you're finished, you'll stop, signal TJ that you're done, and then we will move on to the second task. So get after it and score it at the bottom, and then we'll come back as a group, and then we'll move on to the next. So stop me, TJ, until they're ready. Okay, now I'm back because TJ has started me again. Now, so was that fun? We're going to talk about the results until actually we do both tests. So just hold on to your score for just a minute. So now, the people that just got tested, those that were on the right, get to now test their partner, who is the one sitting on the left. So what you need to do is take out the test that says Stroop Test. On the Stroop Test, the first top part is the one that you want to do first, and you'll notice it says start time and stop time. So you need to actually time how quickly your partner is able to do this. The goal of this is to move fairly quickly through this. So your partner is going to start, and what they're supposed to do is name the color, not what the word says. So, for example, the word red right there, you should not say red, you should say blue, because you aren't reading what the word says, you're saying what the color is. So, you do the top section, they complete that, you have a start and stop time. I'm going to give you a hint, the top part's easier, the bottom part not as much. Then, once they finish that, you have your partner go to the second part, you put the start time and the stop time, and you say the color, not what the word says. So is that clear? So everybody do that. So go ahead, TJ, stop me, and have everybody do this. This shouldn't take but a couple minutes, so do that. And then when you're finished, give TJ a signal that you're finished with that. So go ahead and pause me. Okay, I've been unpaused. So how did you guys do? How many people got 30 out of 30? I'd like a show of hands of the people that got 30 out of 30 on the MOCA. Okay, 29, 28, 27, 26. Gonna stop and not embarrass anybody by going any further. Okay, I'm gonna come back to that. How about the street test? How many people did the second section, the lower part, and made no errors? How many people made like 1 or 2 errors that you noticed? 3 or 4? Again, I will stop the shaming. So you actually should make no mistakes on either of these tests. That is someone that has full normal cognitive function. What? I know. So the reason I wanted you guys to do this is 2 things. One, we ask our patients to do cognitive tests and they're anxiety provoking. How many of you got anxious when you were doing this test? You want to perform. Our patients want to perform. So understanding that when you're doing cognitive testing with patients, you really want to set the stage and try to make them as comfortable about this as you can. In an ideal setting where there isn't a lot of racket going on in the unit and you don't have 15 people on the team staring at them while they're doing this, right? This is something to be done on a one-on-one basis if you're going to do it. The second thing is, even on our best days, sometimes we miss 1 thing or 2 things. It doesn't mean we have severe cognitive impairment, but by doing these tests, if I do this and I have someone who gets a 19 or 20 on their MOCA, there is a problem. That is not normal. Someone gets 27 or 28, they're depressed, they're on some benzos, I'm probably not too worried about that person. But how long did it take you to do this test? That's a nice thing. These tests don't take that long to do. So these are 2 examples of cognitive tests that you guys got to do. Was it fun? Wasn't that fun? I'm so disappointed I don't get to be there and watch you guys do it. Okay, so we already did the how you did part. What happens if you get this from a patient? To the hands you talk, because listening I am not. How many times have you had where you actually want to go try to talk to a patient, get a history, try to do some kind of further evaluation, and the patients are not willing to participate? Like, I don't think I can count how many times that's happened to me this week, let alone, right? So this is a common thing. So another way you can assess cognition is actually doing something called a mini-cog. So instead of the whole MOCA, which a lot of our patients actually will not do, because it's a lot, you can actually have the patient you list 3 words and then they have to repeat them, and then you distract them, and then they have to repeat them after a couple minutes. So you're checking kind of memory, and then you have them do the clock drawing, just like you guys did, and then you have to have you tell them it should say 1:10, so 10 minutes after 1. Then you ask the patient to repeat the 3 words. That's it. So you tell them the 3 words, you have them to repeat the words. The reason they've got to repeat the words is if they actually can't remember the words at the beginning, you know that they have pretty severe impairment versus someone who actually can hold on to the words for a little while. So it's just the words and the clock, that's it. So this is an example of someone with some mild impairment, and this is an example, this is really bad. I have actually a collection of clock drawings that I've taken over the years from patients. They're pretty amazing how difficult some patients can, or how difficult it can be for them. So the score for the mini-cog, if for the 3-word recall, they get 3 out of 3, no cognitive deficits. This is a screening that you could do. So you'd have very little worry about this person. If they get 0 out of 3, they have cognitive deficits. You probably don't need to do a lot more testing at that point. 1 to 2, then you look at the clock. If their clock is normal, it's identified as no cognitive deficits. If it's abnormal, they have deficits. So this is nice because this is actually something a lot of our patients, not all, but a lot of our patients are able to tolerate. This gives us a little bit more information when we're trying to sort out impaired, not impaired. So it's just a good thing to have in your back pocket. So what we're going to do is a couple cases to apply some of this information, and then we'll be wrapping up. this is putting the pieces together here. So we have a 55-year-old gentleman with schizophrenia who was admitted as a John Doe on an ITA. He was found downtown wandering around, was not able to tell his name, very agitated. He was responding to internal stimuli, he was disorganized. This is the third time he's actually come in the last 8 months. And each time he comes in, it's clear that he's been off his medication, so he's not been able to comply with his meds. He was restarted on his olanzapine when he came in, and it's been the med that helped him the most in the past when he's been hospitalized. He gradually starts to recompensate and is a bit more organized, not responding to internal stimuli so much, so his prominent psychosis seems to be softening a little bit. But we've been failing in trying to get him to be more engaged around his medication management. I know this probably sound common to you guys, right? This is something that we see pretty often. So we've been trying to figure out, we want him to stop coming in the hospital. This is his third time in 8 months. He used to be able to manage some of this stuff. This is a worsening in his function that he's experienced in the last year. What we've been doing is trying to have him come and ask for meds as a way of trying to help him get used to doing that, to help him succeed in the outpatient setting. We're getting nowhere. So what might be getting in the way of his success, do you think? What might be getting in the way of his ability to do this? So, thoughts for folks? So I'm gonna have, since I'm not in the room, I'm hoping you're yelling out things. So reasons that he might be having a difficult time with the medication compliance. Okay, since I'm not in the room, I'm gonna go ahead and jump in. So I'm hoping one of the things you're gonna say is cognitive impairment, since that's the topic du jour today. Yes. So that could be one thing. It could be other things, right? Other reasons our patients don't take their medications.
They hate them.
They hate them, right? Non-compliance doesn't always mean that the patient has dementia. They have a severe cognitive impairment. They may have terrible side effects of the medications. They may have prominent psychotic delusions about their medications. They may just be tired of taking medications and don't want to take medications anymore. There's lots of reasons. But sorting this out, how might you sort that out? Right? You'd be asking the patient, what do you think about your medications? Looks like it's been hard for you to take your medications over time. Trying to sort out whether there's ambivalence about it, whether they're just done with medications, or whether it's actually that they can't remember, right? And then you could be doing some of these cognitive tests like we did earlier today to kind of get a sense if there's some cognitive impairment there. All right, so second and last case. The 62-year-old gentleman with chronic severe depression, and he's been experiencing that cognitive decline. His wife actually felt like she couldn't safely manage him in the home anymore, so she transitioned him to a supported living situation. Soon after he moved there, he wandered away from the facility and got lost. I will tell you, the distance he wandered was 1.5 blocks. So he went 1.5 blocks away from where he lived and couldn't find his way back. He was actually found on a park bench. So he was brought to Harborview for treatment for depression. He had been trialed on piles of antidepressants. He'd most recently been started on an MAOI and had a full trial of an MAOI. They did a TCA. He'd been on SSRIs. He'd been on SNRIs. He'd been on a pile of different medications. When we're examining him, he endorses that he's depressed. He's not enjoying things anymore. He's really got prominent apathy. He was very psychomotor retarded. You know psychomotor retardation is not my easiest. It took a long time to get history from him. Not catatonic, but very slow. Appetite was crap, very sleepy. He also seemed confused, like he was not processing information well. We went ahead, so what do you think is going on? So given the history I just gave you, 62-year-old guy, bad depression, cognitive function has been worsening in recent years, and particularly to the point where now wife can't manage him at home. Right, so I'm hoping what you guys are thinking is he could have dementia, right? He could be developing a cognitive impairment. It's a permanent impairment. He also could have what? He could have cognition issues related to the fact that he's depressed, right? I just told you that this guy has lots of symptoms consistent. He's currently depressed. He meets criteria for depression right now. So what would we do for an evaluation for this guy? Is it depression? Assuming all of his blood work is normal and it's not some infective process. Does he have dementia? How would we sort that out? Right, we do some cognitive testing, just like y'all just did. So, we checked the labs, they're all normal. We did a Folstein, which was the one we used to use before we found out it was copyrighted. It was 17. Ouch. He's only 62. This is not normal. The question is then, is this dementia or is this pseudodementia? Because again, you can have this with depression. So that's what we were trying to sort out, whether this is pseudodementia or whether it's dementia, or excuse me, or whether it's something like Alzheimer's dementia. So, this is what happened with this gentleman. This is actually one of my patients. We decided to try ECT because even though he had severe cognitive impairment, as shown by this here, he also had prominent depressive symptoms. So I wanted to make sure that this wasn't someone that had severe depression that looked demented, because once the dementia thing gets stuck on him, once that label gets done on there, people are not going to be aggressively treating his depression. So we gave him ECT. After 12 treatments of ECT, his mini-mental was 30. He had no cognitive impairment at all. So the bottom line is, when someone has severe depression, they can look very demented, and then what you need to do is aggressively treat the depression, because this dementia can fade if the person in fact has pseudodementia. One thing aside I have to tell you about this guy, he always wore t-shirts. He was a big walker, and he would do these walks for various charities, and he always wore dementia t-shirts from Dementia Walks. It was I thought it was a little poignant that he wore those things. Anyway, so we're gonna wrap it up. So you guys know my holy holiday, Halloween, is coming. So I snuck in a little bat. Do you know what that is? That is a baby bat. Shut up, they're so cute. I know, I think they're just the cutest things ever. All right, so cognitive disorders are common. They are more common as we age. There are normal changes that happen with aging, with cognition, but then they can cross over. When they start to interfere, then, and people are going to compensate, you would identify that as a mild cognitive impairment, and then it can get more severe, to be more of a severe cognitive impairment. It's more common to see with psychiatric illness than those in the general population. It can be hard to sort out what's going on because we have a lot of things that our patients experience. The negative symptoms of schizophrenia. Is this person demented, or are they just having prominent negative symptoms with their schizophrenia? Is it that they're severely depressed? Is it they actually have a primary cognitive impairment like dementia? And cognitive testing can really help us kind of tease some of those things out, which hopefully you guys got a taste of. And you guys can do a lot of this. You can do a mini-cog on your patients easily. You can just do they remember 3 objects? There's lots of things that you guys can do bedside to help sort out some of these things. So I hope you guys do. Thank you for your attention. Ciao.